Tetralogy of Fallot, Seoul National University Hospital. Department of Thoracic and Cardiovascular Surgery. Tetralogy of Fallot 1. Definition 2. History. Tetralogy of Fallot is characterized by underdevelopment of right ventricular infundibulum with anterior and leftward displacement. Malalignment of infundibular canal, outlet, septum and its parietal extension. This displacement of septum is associated with right ventricular outflow stenosis and ventricular septal defect. 2. History. Stenson, first description in 1672. Fallot, known tetralogy in 1888. Blalock and Tausig, first surgical intervention in 1945. Sellers and Brock, closed valvotomy and infundibulectomy in 1948. Lilha and Varco, first repair by cross-circulation in 1954. Mayo Group, first repair by pump oxygenator in 1955. Kirklin, conduit used for TOF plus PA in 1966. Tetralogy of Fallot pathophysiology. Tetralogy of Fallot consists of a large VSD, VOTO, aorta overriding the VSD, and right ventricular hypertrophy. VOTO leads to right-to-left shunting across a non-restrictive VSD, resulting in adequate pulmonary blood flow and varying degrees of cyanosis. It comprises 10% of CHD and the most common among the cyanotic defect 50%. Pulmonary infundibulum. Role and its function. The outlet portion of the right ventricle had not only a passive role in right ventricular contraction, and the peristaltic mode may be crucial to achieving a complete emptying of the right ventricular cavity. The delayed opening of pulmonary valve might be more suitably explained by the peristaltic mode of function of right ventricle than by its intrinsic power. The pulmonary infundibulum ejecting the blood that it had accumulated at a time when the rest of the right ventricle was already relaxing. Ventricular interaction. RV and LV interaction crosstalk. While the deeper layer of myocardial fibers are separated, there are shared superficial fibers that encircle the normal LV and RV. Furthermore, in some forms of CHD, such as TOF, the deeper layers of RV and LV may be contiguous within the interventricular septum. The function of the two ventricles is therefore linked, in both the structurally normal and abnormal heart. Tetralogy of Fallot surgical morphology. 1. Right ventricular outflow tract. Infundibulum, pulmonary valve, ring. 2. Pulmonary artery. Trunk, bifurcation, distal PA, iatrogenic problem. Collateral blood flow. 3. VSD and conduction system. 4. Aorta, aortic arch and ductus arteriosus. 5. Right and left ventricle. 6. Coronary arteries. 7. Major associated cardiac anomalies. PDA, multiple VSD, AV canal, ASD, R. Tetralogy of Fallot. Surgical anatomy. TOF. Aorta. PA. VSD. VSD. Tetralogy of Fallot genetic syndromes and outcome. Approximately 10% to 15% of TOF patients carry a 22q11 deletion, del22q11, and that 7% of TOF have trisomy 21. Tetralogy of Fallot patients with Alagille syndrome carry a mutation in JAG1, JAGID1 gene, and Vectal, charge, or other syndromes can be associated with TOF. Patients with TOF and an associated genetic defect may face additional risk for primary repair, for example, if there is the need of extracardiac surgery for associated anomalies or because of immunodeficiency or altered compliance of the pulmonary vasculature. Tetralogy of Fallot clinical features and diagnosis. 1. Clinical presentation. Cyanosis varies with severity of PS. CHF, 10% of patients in 2 to 3 months, and gradual increase in cyanosis. 2. Physical examination. Cyanosis of variable degree and clubbing, systolic ejection murmur. 3. Laboratory studies. Polycythemia, platelet depression, prolonged coagulation. 4. Chest radiography and electrocardiography. 5. Echocardiography, kinetic angio, MRI. 6. Cardiac catheterization and angiocardiography. Tetralogy of Fallot, natural history. 1. Incidence. One of the most common CHD. 3/6 10,000ths births, 5% × 10% of CHD. 2. Symptoms and survival, 25% death in 1 year. 40% death in 3 years. 70% death in 7 years. 95% death in 40 years. 3. Hypoxic spell, hyperactivity of infundibulum. In the first year of life and sudden reduction of SVR. 4. Pulmonary artery thrombosis, in severely polycythemia. 5. Pulmonary vascular disease, rarely. 6. Genetic history, more likely, X15. Tetralogy of Fallot, operative indications. Diagnosis is generally an indication for repair. 1. When asymptomatic and uncomplicated, repair is deferred until 3 to 24 months of age. 2. Initial shunting operation for symptomatic patient. Less than about 6 months of age, and definitive repair sometime between 6 and 24 months of age. 3. Early primary repair when the infant is importantly symptomatic in the first 3 months. 4. Early repair is advisable, particularly in the first year of life. Tetralogy of Fallot, aim of repair. First, the procedure must relieve the right ventricular hypertension, PS, by mobilizing, transecting, and infrequently, resecting parietal and septal extensions, bands, of the crista supraventricularis. The aim of infundibular dissection is to increase the circumference of the infundibulums by enlarging each lateral recess in front of the conal septum. Second, the VSD must be closed completely while avoiding the conduction system. When the first criterion is met by a right atrial approach, it is considered the method of choice. Tetralogy of Fallot, operative techniques. 1. Evaluation. Shunting versus one-stage repair. Z-valve of pulmonary annulus. 2. Surgical approach. Provide excellent exposure. Avoid damage to coronary artery. Avoid excessive muscle division in RV. 3. Details of repair. Transventricular repair. Transatrial and transpulmonary repair. Systemic pulmonary shunts. Tetralogy of Fallot. Systemic pulmonary shunts. Various positions of the usual systemic pulmonary arterial shunts for augmenting pulmonary blood flow. Systemic pulmonary shunts. Via median sternotomy. Anatomic substrate of repair from right ventricular approach. Tetralogy of Fallot. Anatomy. Anatomic substrate of repair from right ventricular approach. Anatomic substrate of repair from right atrial approach. Tetralogy of Fallot. Anatomy. Anatomic substrate of repair from right atrial approach. VIT reconstruction principles. The diameter of annulus with a hyperdilator that passes snugly but not tightly through it. Generally, a transannular patch should not be placed when Z value is larger than -3. When a polyester tube is used, one is selected whose diameter corresponds to a Z value of 0 to +2. The patch, when properly trimmed, its convexity is ensured in all direction, as is a relatively square cut of its distal end. To widen the LPA stenosis, a rectangular piece of pericardium is cut about 1.5 times wider than the apparent diameter of the LPA and about 1.5 times longer than the incision in the LPA. VIT reconstruction application of monocusp patch. Transannular patching is often necessary for reconstruction of right ventricular outflow tract obstruction, but it leads to transvalvular regurgitation. Acute pulmonary valve regurgitation of higher degrees impairs right ventricular function, and seems to be associated with increased perioperative mortality. Regurgitation fraction after reconstruction is dependent on the length of the monocusp patch relative to the length of the hyperplastic pulmonary route. The best result was obtained with a monocusp patch roughly 2 times as wide as the hyperplastic pulmonary route. Vit patch widening principles. The width of the patch across the pulmonary annulus must be generous enough to eliminate most of the gradient. It is better to accept a mild to moderate gradient than to create wide-open pulmonic insufficiency. The new annulus diameter should not be much greater than the Z0 pulmonary annular size for the patient. The toe of the patch must be oval or square to minimize the risk of subsequent anastomotic stenosis. Tetralogy of Fallot. Surgical repair. Tetralogy of Fallot operative technique. The rectangular patch, when properly trimmed, its convexity is ensured in all direction, as relatively square cut of its distal end. Tetralogy of Fallot patch enlargement. Extension of a pulmonary arteriotomy onto the left pulmonary artery and correct patch configuration. Vit reconstruction 1. Tetralogy of Fallot. Vit reconstruction 1. Monocuspid valve, Vit reconstruction 2. Tetralogy of Fallot. Vit reconstruction 2. Monocuspid valve may be attached to the pericardial roofing patch. The cusp diameter is fashioned somewhat larger than the planned roofed RV outflow. Vit reconstruction 3. Tetralogy of Fallot. Vit reconstruction 3. It is cut more or less circular and sutured to the patch when the latter suturing from distally reaches the valve annulus, pulmonary valve saving. Tetralogy of Fallot. Pulmonary valve saving, pulmonary valve saving. Tetralogy of Fallot. Pulmonary valve saving, pulmonary valve sparing. Tetralogy of Fallot. Pulmonary valve sparing. A. Pulmonary arteriotomy. B. Autologous pantaloon pericardial patch. C. Completed pulmonary artery pantaloon patch. Tetralogy of Fallot postoperative care. Patients have a tendency to increase their interstitial, pleural, and peritoneal fluids early postoperatively. The hemodynamic state is assessed continuously and management constantly reviewed. Careless loss of intravascular plasma to extravascular spaces produces undesirable hemoconcentration early postoperatively. Bleeding because of preoperative polycythemia and depletion of many clotting factors, extensive collateral circulation, and damaging effects of CPB. Body weight is followed closely because transient fluid retention is common, especially transannular patch. Post-repair RV pressure. Factors of PRV/LV. Pulmonary arteriolar resistance. Size of the LPA and RPA. Presence and severity of localized or segmental stenosis or incomplete distributions of pulmonary arteries. Residual pulmonary trunk or RV outflow obstruction. Increased flow through Vit by residual shunting and by pulmonary regurgitation. Tetralogy of Fallot special situation and controversies. Rationale for use of post-repair PRV/LV. Initial palliative operations preferred median sternotomy in all age. Palliation by beta-adrenergic blockade 2 to 6 mg/kg/day. Initial palliation by balloon valvotomy. Monocusp valves beneath patches. Tetralogy of Fallot neurodevelopmental impairment. Neurodevelopmental impairment is known in children after palliative or corrective surgery for cyanotic heart disease beyond infancy. Preoperative impairment, however, due to prolonged chronic cyanosis with thromboembolic or septic brain damage, should be markedly reduced in Fallot patients without preoperative complications and operated on during infancy. Influences of preoperative and perioperative conditions with elevated circulating levels of pro-inflammatory cytokines in hypoxemic patients might be also in part responsible for damage to the brain. Tetralogy of Fallot surgical results. 1. Survival. Early death, recently less than 1%. Time-related survival, good. 2. Modes of death, subacute heart failure. 3. Risk factors for premature death. 4. Heart block, arrhythmia, sudden death. 5. Right ventricular function and aneurysm. 6. Residual outflow tract obstruction. 7. Left ventricular function and functional status. 8. Residual VSDs and bacterial endocarditis. 9. Pulmonary function. 10. Reoperation and other reintervention. Risk factors for premature death. Post-repair tetralogy of Fallot. Risk factors for premature death. 1. Very young age at repair. 2. Older age at repair. 3. Severity of annulus hypoplasia. 4. Size of pulmonary artery. 5. Transannular patch. 6. Post-repair PRV/LV. 7. Previous palliative operations. 8. Multiple VSD, 1 to 3%. 9. Coexisting related cardiac anomalies. ECD, Down syndrome, MAPCA. 10. Other risk factors, small LV, primary repair of TOF advantages in early infancy. 1. Avoidance of the risk of palliative operation. 2. Prevention of shunt-induced PA stenosis. 3. Obviation of the need to take down shunt. 4. Early relief of RV hypertension. 5. Avoidance of excessive LV volume load. 6. Elimination of right-to-left tenant shunting across VSD, Tetralogy of Fallot benefits of early complete repair. Normal growth and development of organs. Elimination of hypoxemia. Less need for extensive right ventricular muscle excision. Better late left ventricular function. Decreased incidence of late dysrhythmias. Tetralogy of Fallot late problems after repair. Late death, sudden cardiac death. Radio operation. Aortic root dilation, R and AVR. Residua, sequelae, PR, TR, VOTO, VSD. Arrhythmias, SSS, CAV, AF, AFL, VT. Impaired cardiopulmonary performance. Impaired autonomic nervous system. Ventricular dysfunction, RV, LV failure. Infective endocarditis. Results after TOF repair. Risk factors for late death. Residual VSD. Residual RV outflow stenosis. Severe PR. Severe TR. Older age at repair. Previous POTS, or Waterston shunt. Tetralogy of Fallot considerations in adult. Collaterals or pre-existing shunts lead to increased pulmonary blood flow, and together with myocardial hypertrophy and myocardial hypoxia, they lead to reduced biventricular function. Impaired ventricular function, severe hypoxemia, and tricuspid regurgitation are associated with a higher operative mortality, whereas the influence of age at the time of operation is controversially. Cyanosis and erythrocytosis lead to thrombosis, infective endocarditis, stroke, brain abscess, myocardial fibrosis, impaired ventricular function, and multi-organ dysfunction could be the most important risk factor. Tetralogy of Fallot risk factors in adult. Prolonged cyanosis causes myocardial and other organ dysfunction. Heart is chronically volume overloaded, especially in previous palliative procedures and aortopulmonary collaterals. Bleeding tendency is also important. The non-compliant hypertrophic adult right ventricle seems to tolerate pulmonary valve regurgitation poorly, the second significant predictor of early mortality being the need for right ventricular outflow patch. The native pulmonary valve is of course preserved and repaired whenever possible. Results after TOF repair. Causes of sudden death. Bradyarrhythmias such as complete avenue block, bifascicular block, SSS. VT and residual VOTO and RV dysfunction. Complex ventricular arrhythmias by Holter monitoring. Monomorphic VT and severe PR. Peripheral PS, RV dilation, QRS duration more than 180 ms. Arrhythmia and sudden death. Approaches after TOF repair. QRS. Easy to measure. Reflects RV size. Dynamic nature, QRS change important. New QRS cutoff values for contemporary cohorts. QT dispersion. Refines risk stratification. Less dynamic. May reflect initial ventriculotomy scar/VSD closure. Sudden cardiac death mechanisms of SCD after TOF repair. 1. SCD and sustained VT in common. Electrophysiologic profile. Long QRS. QRS change. QT dispersion. Hemodynamic substrate. PR moderate/severe. Cardiomegaly/RV dilation. 2. SCD different from sustained VT patient. Old age at repair. 3. Overlap between AF/AFL/sustained VT and SCD. Tetralogy of Fallot causes of ventricular dysfunction LV dysfunction. Secondary to inadequate myocardial protection during initial repair. LV volume overload due to long-standing palliative shunt or residual VSD. Myocardial fibrosis because of long-standing cyanosis or VOTO. RV dysfunction. Residual VOTO. Long-standing PR, TR. Surgical scar, RV and/or patching, aneurysm. Autonomic nerve system. Impairment after TOF repair. Reports demonstrating depressed heart rate variability and baroreflex sensitivity suggest that the autonomic nervous system change may also involved in arrhythmogenesis. Also depressed heart rate was observed in repaired TOF patients during exercise and pregnancy. Aortic root dilation late after TOF repair. Shunt to repair time interval. Male gender. Pulmonary atresia. Right aortic arch. Aortic regurgitation. LV enlargement. Tetralogy of Fallot mechanisms of aortic root dilation. Underlying abnormality. Reciprocal morphogenesis of aorta PA. Increased flow from both ventricle. Abnormal morphology. Intrinsic medial abnormality. Acquired hemodynamic influences. Increased flow through aorta. Increased volume/pulsatility. Infective endocarditis. Surgical damage. Residual VSD. Pulmonary artery lesions. After TOF repair. Incidence of reoperation, 5–14%. Reasons of risk stenosis of VOT. 1. Restricted growth of VOT. 2. Miscalculated sizing of VOT. 3. Angulation and stenosis of LPA. 4. Compression/angulation of PA caused by RV hypertrophy or dilation. 5. Most common location is pulmonary. Bifurcation or origin of PA branch. Pulmonary artery stenosis. Branch stenosis after TOF repair. 1. RV dilation, pulmonary regurgitation after transannular patch as primary phenomenon. 2. Pulmonary outflow dilate and elongate craniad and rotate to left resulting in kinking and obstruction of previous normal left pulmonary artery. Left pulmonary artery stenosis. Operative principle. 1. Removal of redundancy at the kinking point. 2. Effective shortening of the dilated and elongated pulmonary trunk by reduction angioplasty or conduit of shorter length. 3. division of intact ligamentum arteriosum. 4. Conduit reconstruction of the vit with shortening. Pulmonary trunk allowing LPA to be pulled down. Or reimplant LPA proximally with favorable angle. Vit aneurysm complications, airway compression. Pulmonary perfusion asymmetry. Thromboembolism. Ventricular dysfunction. Increase of pulmonary insufficiency. Rupture. Unilateral absence of PA. Pathogenesis. The proximal pulmonary artery branches developed from the proximal sixth pharyngeal arches. Non-confluence of the pulmonary arteries may be due to regression of the sixth arch segment as part of conotruncal abnormalities. There was no channel from the right ventricle to a main branch pulmonary artery with a disconnected PA. Dissection to pulmonary hilus revealed an identifiable patent artery. There is high incidence in this post-mortem study of right aortic arch and an aberrant subclavian artery. Unilateral absence of PA. Pathophysiology. The importance of previous ductal flow and the loss of pulmonary arterial flow with duct closure after birth. The prevalence of a diverticulum of the innominate artery was viewed as evidence of previous duct-dependent arterial flow. The diverticulum represented a fetal systemic blood supply to the affected lung through the distal part of the sixth aortic arch. Early repair is the key in treating this anomaly because of the risk of early obstructive pulmonary disease and to avoid pulmonary hypertension or ultimate sacrifice of the affected lung.